I am so tickled today to have the chance to talk to Elizabeth Bonefas. Dr. Bonefas is a legend here at the Rose. In the breast cancer community, she is someone who we all admire, someone who really stands up for her patients, someone who's been doing this a long time, almost as long as the Rose. And she's also a physician who not only helped us with a lot of patients who were diagnosed with cancer, but with our youngest ever diagnosed breast cancer patient. Her story is one of love and caring and of being a woman at a time when women were not accepted that much and who refused to take no for an answer. When you subscribe to our show, you help us grow. Someone you know may need to hear this story, so please share with your family and friends and consider supporting our mission at therose.org. Let's talk about your breast. A different kind of podcast presented to you by The Rose, a breast center of excellence and a Texas treasure. You're going to hear frank discussions about tough topics, and you're going to learn why knowing about your breast could save your life. Dr. Bonefas, thank you so much for being with us today. You know, you're a legend. I mean, you are a legend in all of the breast cancer world in Houston area. I don't remember a time when I didn't know about you, but as you were saying, you were at St. Joe's. Yeah.
I did my residency at St. Joseph from 1984 to 1989, and then when I came out, I chose to stay in the Houston area, went into practice with Dr. Kramer, stayed with him for approximately 4 years, and then took the big plunge and went out on my own.
Are you still solo?
Yeah, pretty much. I share offices with Dr. Concepcion Aristides.
Oh, yes.
Yes, she's in gyn oncology. We felt like that was a good marriage, so to speak, so we share office space, and that's worked out very well. But yeah, in 1989, went out into private practice, and then in 1993, went out really on my own. And since that time, I've been out on my own. I've had occasional people that I've shared office space with, and that's how that's gone. I've been at Baylor College of Medicine since 1994.
Okay.
And that's probably been my biggest introduction to the Rose because I was at Ben Taub in their general surgery and breast clinics.
Right, and you took care of so many of our patients.
Yes.
Oh, that was a really tough time. We had just started doing ultrasounds and biopsies at that time, and so the whole environment was changing, and you couldn't just call on people to get folks in anymore. It was really a tough time. We were so grateful for Ben Taub.
Yes.
We really were.
And that was a win-win for us because we had a lot of young surgeons eager to learn. And so those patients would come over and we gave them really good care because we also were affiliated with Baylor College of Medicine. We had access to their oncologists. And that worked out very well.
Oh, it did. It really did. Did you always want to be a doctor?
Yes.
Really?
Yes. I had one little time when I told my dad that I wanted to be a forest ranger.
Oh,
and he said, okay, well, forest ranger, you can go to college, do that, and you're on your own, or I'll help you if you decide you're going to go to medical school. And I went, I think I will go back to my original decision of going to be a doctor.
But now that's such a...
I know.
I know.
But when you're a teenager, you know.
Oh, wow. Okay. Yes. So he encouraged you somewhat.
Yes, but my mother is probably much more of the encouragement for me. She started out as a medical technologist, worked at Herman Hospital, and then worked with Brown and Associates, which is a private laboratory here in Houston for many years. But she had wanted to be a doctor. Then met my dad, had 5 kids. And then at the end he goes, well, you could go back to medical school. And she goes, no, that time has passed. But I was very interested.
So were you youngest, oldest?
I'm the oldest child.
Oh,
yes.
Yeah.
Yes.
Well, how neat. That's a good story. Yeah, that she got you really going. But why did you pick breast? Now, you're a general surgeon first.
I'm a general surgeon. So when I came out, I was doing all the general surgery things. Mm-hmm. So there was a lot of breast, gallbladders, trauma, all of it. And as I went through my practice, women started to want to see women. Mm-hmm. And so I started seeing a lot of women wanting for breast, also for gallbladders, hernias, and such. But I ended up with probably at one point 75% breast in my practice. And I went, okay. And one night my son called, and he was 9. You haven't been home all day. And I'm in surgery, doing an appendectomy at like 10 o'clock at night. Dad says I have to go to bed. And I was like, oh, man, daggers. And a friend of mine, Beth Dupree, who's up in Pennsylvania, had told me a couple months before, you should really just go to breast because it's very fulfilling. Lots of patients, the surgery's interesting, and you can manage your life a little bit better. And you have a child, and you're going to want to get to the point where when he's in junior high and high school, you can be there a little bit more.
Oh, yeah.
So that's why it was kind of a lifestyle thing, but it was also kind of it's time to do that.
Before we continue this episode, I have to let you know about something that is happening throughout this month of July. Our anonymous donor is at it again, and she wants to match your donation up to $100,000. So think about it. $20 is now $40, $100 is now $200, and if you're feeling really generous, $1,000 is now $2,000. Just think about all the women that we could help with your donation and our anonymous donors match. Please go to therose.org. It's easy to make your donation there. And as our donor said, every dollar counts. Now back to the podcast. How different is it now from those early days at Bentob?
Oh, it's changed tremendously, actually. The system itself has changed. I think when I was a resident, walk through the snow, blah, blah, blah. And no, when I was a resident, there was a lot less, if you were in the Bentob system or a system like that, there was less supervision in a way. You were supervised, but you had a little bit more freedom. You certainly worked a lot more hours. Mm-hmm. But as they started looking at education for surgeons, they realized that you had to have people in the OR that kind of knew or were interested in what that was. And so they now have very good professors that in the OR that do all of that in the clinics, because it used to be young doctors would be in the clinic. You could access someone, but it's a little different when someone's right there and you can just turn around and go, hey, Dr. Smith, what about this? Right. And get some input.
So has the surgery changed a lot from what?
Surgery itself, I will say surgery for breast has changed a lot.
Okay.
So as a resident, I spent 6 months at MD Anderson. I did so many mastectomies, and it was the modified radical mastectomy. You took out all the lymph nodes. You did all of in women, and that time that was before ultrasound. A lot of ultrasound biopsy. You would take a woman to surgery. You would say, "We're going to do a breast biopsy. We're going to send it to pathology. If this comes back as cancer, you're going to wake up without your breast." Now that's a very difficult thing to place on a woman. No matter what age you are.
Right.
So that was tough on women. And so you go into the 90s and they decided, okay, well, you could do the biopsy and you didn't need to do the mastectomy right then. You could make some decisions because we were starting to do more lumpectomies. We were still doing all the lymph nodes. Then you got to where you were doing ultrasound and stereotactic biopsies. So you had the ability to plan your surgery. And the partial mastectomy was gaining more momentum because the studies were starting to show that the survival rates were the same whether you did a complete mastectomy or a lumpectomy. But it took some time for that to come along.
It took a long time, it seems like. Yeah.
It did. Then you go, and we're still doing a lot of taking out all the lymph nodes, the lymphadenectomy.
Yeah.
And you're having to deal with the issues with the lymphedema, which can be very devastating because it can be very difficult to control. And about 1995, they came out with this sentinel lymph node biopsy, where you could take out a lymph node. At that time, because it was so new, we would check the lymph node. If it was positive, then we would do the axillary dissection. We continue to go through the studies. Then they figure out, oh, guess what? Z11 comes out. It's a study where they looked at doing sentinel lymph node alone or sentinel lymph node with axillary dissection. And the upshot of that study was that if you had 2 or less positive nodes, so 1 or 2 positive nodes, you didn't really get any benefit by taking out a bunch more nodes.
Yeah.
You could continue on with your radiation and whatever treatment, and you had the same survival rates. So it's like, well, that's good because when you're doing only a sentinel node, your lymphedema rates are only about 5%.
Right.
Whereas if you're having to do a complete lymphadenectomy with or without radiation, you're going to run into the 30 to 40% range. So that was good for women.
Oh, yes. Oh, yes.
So now we do a lot more lumpectomy with sentinel lymph node. Still a lot of radiation. Radiation has changed because instead of doing 6 to 7 weeks, 30 to 35 treatments, now we're down to 15 to 20 treatments, depending upon what you have. There are protocols for certain tumors where you can just do 5 days, which partial breast. So that's very helpful.
Oh,
and it's a game changer. You've got women who used to live, say, way out in the country and to come in for a couple of hours or, 2 hours in, 2 hours back just to do
one
quick
treatment. Yeah.
quick radiation treatment. They just didn't have the time.
And if you were uninsured, like so many of our patients, you couldn't take off work to do that. And that's, we were so curious why once we finally had Medicaid breast and cervical cancer cover, Reconstruction and all of those things, we thought, every single one of them will want to have that. No, because having the mastectomy was going to let them get back to work faster. Yes. And that just infuriated me. Yes. I can remember how frustrating that was, but then they had family to feed.
Yes. And that, kind of ties into with, and this is one of my pet peeves, it's just how expensive the whole cost of it is.
Yes.
Because even if you're insured these days, I have people walk in, well, my deductible is $5,000.
Right.
And I'm going like, well, okay. You go get a biopsy. If you're going through one of the systems like Methodist or Herman or, you're going to spend, they're going to ask for pretty much all of your deductible. And so you get there very quickly. But most of us, really don't have $5,000 just to slap on the table to do this. The other thing that really bothered me about a lot of that was that you could, if I could see it on ultrasound or feel it, it's much cheaper for me to do it. If a patient asks for cash price, it's much cheaper. But the way all these insurance companies and stuff run, they don't put it towards your deductible. which is, I feel, is very unfair.
And what happens to young women, I mean, it's like, it's going to be called diagnostic. It's going to cost more.
Correct.
It's, most of all, it's misdiagnosed so many times because they are young or they've just had a baby or we've had so many guests. Same story over and over.
Yes.
Whether insured or not insured. Either way, it was a real hassle to have to try to get in.
Yes. Case in point, I saw a young woman today. Biopsy shows cancer. She's 36 and 3 kids at home. No insurance, but her husband said, we'll get insurance. And I'm going like, and I know what Marketplace is going to do to you. Mm-hmm. But she's going like, it took me so much time just to get in to get a mammogram and ultrasound. Then I had to get the biopsy. Then now I've got to see you. And she's feeling very pressed.
Oh, yeah.
But, and I know she has to have the insurance or it's too expensive.
Yeah.
And then I love that Medicaid plan for breast and GYN. Mm-hmm. The Rose, I know, worked very hard for that too. But it saved a lot of lives because there were women who they just wouldn't do anything about it. Mm-mm. Or they get to a point, it's like, well, I can't afford that. I'm not going to do that.
Yeah.
So it helps.
Yeah. Oh, absolutely.
It helps.
But still,
it's really tough.
We have said this often, healthcare for women in Texas is just not what it could be, and especially uninsured women. It is very, there's not enough, and it's too hard to get. And, we diagnose 450 to 500 women every year.
Yes.
Half of those are uninsured.
I believe that.
And, the changes that are happening now, I mean, it's very scary.
Yes, it's getting harder and harder. It's also harder because, so I'm in private practice. I'm half-time at Baylor. So if you don't have any money, don't have any insurance, you can call my office. I'm going to give you a cash price, and then I'm going to try my darndest to get you in by hook or by crook,
right?
Some way to get you covered into that. But if you were to come see me at the Baylor College of Medicine, it's very expensive.
Very expensive, yeah.
And to get into a place like MD Anderson, you have to be the Sheik of Araby to be able to plunk down the money.
Right, and you probably know they do not take the state plan.
No.
So that has been off the table for our ladies since 2017.
Yes.
Yeah.
Yes.
It's just, and where does everyone want to go?
Anderson.
Of course.
Of course they do.
And, believe me, they do great work.
They do.
We know. But it's just, it's not the same when you're uninsured or poor or, even right now, the co-cap isn't covered.
No.
Why? I mean, what's it going to take to get that covered?
Why is that? And that's cheap compared to a lot of the other things they'll cover. Or things that they'll cover that are benign or whatever. Mm-hmm. And you're going like, really? You'll cover that, but you won't not do this?
This, yes. And, for our ladies, many times they still have that limit of the number of medications you can have.
Yes.
And so what are they supposed to do? They have no idea which one to give up.
Right.
And they have to give up one because they don't have the money out of pocket to go and get it.
Right.
It's so frustrating.
And I know pharmacy is a tremendous part of the whole breast cancer experience. Mm-hmm. So if you're looking at women who need and I remember when people would fall into donut holes for tamoxifen and Arimidex and all that, and you're just like, and they're going like, I don't have $400 a month to pay for this medicine.
Oh, I remember one patient saying to us, if I had $400 a month, I'd have insurance.
Right.
I mean, how am I supposed to do this? Yeah.
Right. And so when they've changed a lot of the, there are a lot of bad things that are said about the pharmacy industry, but back in the day, your reps would come around and they would leave samples, and you'd use those samples to cover your underinsured or non-insured patients. But you don't have that luxury anymore. I mean, because it's for whatever the powers that be think. They think, well, everybody is, number one, supposed to have insurance by law, right? Yeah. We're supposed to. That's not really feasible when you look at what the cost of insurance is. I mean, so people, try and catch as they can. It makes me growl a lot. Mm-hmm. I think that is something that going forward, I hope that people will get more of a sense of how we need to re-examine what's going on. You got a new administration. Why don't y'all look at pharmacy? Why don't you look at women's health? Because you have to have your moms and your women healthy to be able to go forward in this world. So that's
I'm not too well.
I don't know. Mm-hmm. But every time I don't know that they'll do anything. It always seems to me that there's always just something else that they need to be more in touch with than what I want them to be. Because I want people to have health care coverage. I want it to be reasonable. Mm-hmm. I don't think a $5,000 deductible is a reasonable thing with another $3,000 co-insurance or whatever. I mean, by the time you pay all that, if you are on you could be making $70,000 a year and have a couple of kids. You're not going to be able to afford that. Mm-mm. And so you end up paying all that money. And so then if you need it, okay, it's there catastrophically. But most of the time you've already paid for everything.
Right.
Right.
So, what else would you change, Dr. Bonefas?
Yeah, I would change drug costs. I think access has always been a problem. Mm-hmm. I don't think that, I hear lots of complaints about Medicaid. I understand why physicians don't like Medicaid because it can be very difficult to cover your costs. Oh, yeah. And so it's like, well, that's great. You can see people. I can see lots and lots of people, but if I can't pay my bills to keep my doors open, what's the point? So I think that has to have a
But
work.
even with Medicare, it's so fascinating to me that unless you're in the healthcare world, we think insurance does it. But there's different kind of insurance and there's different kind of coverage, and it makes it harder and harder for the physician or an imaging place to provide all you want to provide because there's just no coverage. Our patient navigation program has no reimbursement. Right,
and that's true in all of these, like Baylor, HCA. They pay for it because. Right. I think those systems are looking to try, if they've got patients in the system, to keep them captured. Mm-hmm. That doesn't always help me as a private practitioner trying to get my patients navigated through a system, because if I'm not going to use HCA or I'm not going to use Baylor, where do I go? Where do my patients go? They don't pay for navigation. Genetic counseling is actually not paid for.
It's not. And we're doing that now, just for you to know.
Oh.
And we're doing it through Natera is helping us with our uninsured people. So, hey.
Yeah. No.
Why not?
Why not? I know the Rose has always done a very nice job about getting prostheses and cranial prostheses.
Yes, yes, we
women.
have beautiful wigs, beautiful.
So, but a lot of women can't afford some of that, or their insurance company doesn't cover that. Mm-hmm. The other issue for me is because as a surgeon, a lot of times I have a patient who she chooses mastectomy. She'd like to have a reconstruction. But in some of these plans, you cannot find a plastic surgeon who will take it because for them, they just can't make their costs, And so you just bang your head against the wall and you just keep trying. And some patients will go, look, I will just do what you need to do for the cancer and we'll worry about the other later. I can do the bra and prosthesis, I can do this. Radiation is a problem, very expensive. So I, was very glad to see that these costs to a certain extent have come down because those were always paid for, as you would say, by the click. So the radiation for breast, if you can do a 5-day course, is going to be much cheaper than 6 to 7 weeks.
Absolutely.
So that's been a plus, but I don't see that those costs are coming down so much that a patient could just walk in and she goes, well, I've had this. How much is radiation going to cost? They still will put it at, that'd be $20,000, $30,000, $60,000.
Right.
Yep.
So are you seeing more young women now, do you think?
Yes.
Yes, we are too.
I've been seeing women in their 20s. I've got a couple of them, 25. I'm just like, I just diagnosed a 31-year-old.
We should compare because, what people say to me is, oh, there's better screening. There's no screening for young women.
No, there's no screening. We fought hard just to get the U.S. Prevention Task Force people to agree to go back down to 40.
40, yes.
It's like, I would have patients walk in, well, what do you think about screening? They say I don't have to do it till I'm 50. I'm like, okay, well, let's have a little session on that, If you look at those studies, and they're mostly, they base all that stuff out of the European studies, because that's what the Europeans do.
Yes.
Those are women who have nothing that would suggest that they're going to have breast cancer. So they don't have a family history. Mm-hmm. They start their periods when they're supposed to. They go through menopause when they're supposed to. They have their first child before, the age of 35 or whatever. They don't ever use hormone therapy replacement, and they've never had a biopsy that showed atypia, right? Yeah. And you're going like, okay, and then add to that, you're overweight. Mm-hmm. Okay, probably at least 50% of America is overweight. Yes. So a lot of us women are overweight. That is a risk factor, and you don't exercise. I don't have any time. The kids have this. My job says that. You got to find the time to exercise. You got to take that time out for yourself to do it. But they don't. So if you're not going to do those things and you don't meet all those criteria, you should be getting your mammogram starting at 40.
Absolutely.
Absolutely. And how many women have we diagnosed in their 40s who would have met all those criteria?
None. Handful, if a handful, yes.
Yeah, they all have,
something.
They have family history, they have, it's usually family history, and then they'll present with a lump, and you're just like, okay. Because I had people complain about mammograms. I said, no, you don't understand. You want to find it on mammogram and ultrasound.
I know. We had someone, I remember, a huge criticism. Well, as long as you tell people that you're going to find it, why are you telling women they're going to find it? I'm going, how else are you going to say this? It's like, we are not children. No. We don't need to be patted on our heads and told, oh, well, this isn't going to matter.
Yeah.
Mm-hmm. I know.
Yeah. So,
well, I'm glad to hear that you're promoting mammograms.
Yes, and it's tough for women because they'll hear, oh, it hurts. I'm going like, Okay, I've been getting mammograms since I was 40. It's uncomfortable. It's gotten a lot better with digital mammography. And I think if you can, it's much faster than what it used to be. And the imaging is much better. The callbacks are less. And they'll go, but you could do an ultrasound and see the same thing. I said, happens that it's complementary. That's complementary, not they don't rule each other out. You're not going to find calcifications on ultrasound, but if, say, you're diagnosing lobular carcinoma, you may see that on ultrasound and not on mammography so much. I would like to see it so that it wasn't such a pain in the butt to order a screening ultrasound, especially when the radiologist says, I really think with the dense breasts, I would like an ultrasound. Now, as doctors, we all understand that that's not a true screening test. Now, they were working on screening ultrasounds, the bus and such like that, but it's hard to get that stuff paid for. Oh, yeah. And the machines are expensive. You've got a learning curve with your ultrasonographers that you've got to go through. You've got to train people to do it. And it hasn't really caught on as well here. But a lot of the breast radiologists are very good at just regular old ultrasound. And I'm always impressed with the techs.
Oh, yeah.
Yeah.
Oh, yeah.
Come here.
Yes.
Let's look at this.
Right. They know.
They know. But it's getting the codes, because there are actually codes to do it. It's just convincing your insurer to pay for it.
Yeah, that is it.
So,
well, thank goodness you take some people who don't have insurance, and thank goodness you've taken care of so many of ours. I will tell you, we wouldn't have made it without you.
Oh.
No, I'm very serious. Very serious. And thank you so much for being with us today.
It was my pleasure.
Making this trip and coming in. Oh, it's such a delight to see you.
It is always a delight to see you, Dorothy.
Thank you for joining us today on Let's Talk About Your Breasts. This podcast is produced by Speak Podcasting and brought to you by The Rose. Visit therose.org to learn more about our organization. Subscribe to our podcast, share episodes with friends, and join the conversation on social media using hashtag Let's Talk About Your Breasts. We welcome your feedback and suggestions. Consider supporting The Rose. Your gift can make the difference to a person in need. And remember, self-care is not selfish. It's essential.